Clinical documentation is a vital part of patient care. Failure to maintain accurate and complete patient information can have negative consequences, such as poor patient outcomes and compliance violations. Done right, it helps prevent medical errors, protects your license, keeps your agency compliant, and ensures patients get the quality care they need. In this video, we'll go over the do's and don'ts of documentation, along with some practical tips to make your charting easier and more efficient. Let's get started. Here are some key strategies for effective documentation in home health. Avoid documenting trips outside the home not covered within homebound guidelines. If patient is no longer homebound, notify the case manager for discharge planning, orders, and discharge evaluation. Use assessed in place of observed, discussed, encouraged. Observation, discussion, encouragement do not require skilled expertise to accomplish and may raise questions of medical necessity. Avoid the use of feeling better or healing well. Instead of saying feeling better, you can say patient reports improved pain. States pain to her right knee is currently a 3 out of 10, improved from last visit's rating of 8 out of 10. Instead of saying wound healing well, describe the actual wound, such as wound remains open with minimal drainage, edges well defined, wound bed covered with pink granulation tissue. No odor or signs of infection noted. Do not say the wound is completely healed unless documented as healed by a physician. Some wounds may close but are still not healed. For example, stage 4 pressure ulcers are never considered completely healed even if closed. Instead, use approximated, closed, with scab or scar tissue, epithelialized, etc. Use teach or instruct instead of supervise. Use assess instead of monitor. Supervise and monitor denote stability. Avoid use of independent unless discharge plans have been initiated or the mentioned area of independence will no longer be part of continued care, as this can raise questions of the need for skilled care. Avoid use of re-instruct and reinforce, as this denotes repetition. Duplication of care is not covered by Medicare. To use these words, you must indicate proof of the need to reinforce or re-instruct, such as caregiver noted to attempt to perform wound care without donning gloves, increasing risk of potential wound infection, teaching reinforced on infection control. Avoid saying family is unwilling to care for the patient. Instead, use words such as unable, unavailable, overburdened, or overwhelmed with care, or own responsibilities, not in home, or are ill. Document why family members in the home cannot be taught to perform certain duties or procedures and interventions done. Avoid documenting presence of a private sitter or companion if home health aid services are also being provided by the agency. If there is help, a home health aid is not needed. Notify the case manager immediately. Document based on facts, not opinion. Do not make biased conclusions. Example, don't say patient is being abused. Instead, document what you see. Example, patient noted to have multiple unexplained bruises to right arm, left leg, and left cheek. Make documentations as concise as possible. Document specific details instructed on. For example, instead of patient instructed on signs and symptoms of diabetes, list the actual signs and symptoms instructed on. Example, patient instructed on the following signs and symptoms of diabetes: increased thirst, blurry vision, frequent urination, etc. Document patient, caregiver specific response to teachings and instructions given. Example, patient caregiver was able to recall increased thirst, frequent urination, and blurry vision as signs and symptoms of diabetes. Do not say the patient is not at home if no one answers or opens the door. Instead, document that there was no answer to locked door with multiple attempts. Indicate other contact methods used to ensure the patient is not home. This covers instances where the patient was not able to come to the door because was unconscious, deceased, fell, etc. All missed visits must be reported to case managers on the day missed for follow-up and rescheduling. When documenting, keep in mind the reasons why this patient is homebound and why there's a need to be seen by a skilled nurse or any other skilled disciplines. Ensure that notes reflect the need for skilled intervention and are medically necessary. Your charting should focus on identifying existing and potential problems. Paint a vivid picture of what is going on in the home. Avoid happy charting that can result in denial of payment. Ensure that teaching is relevant to your patient. Example, your teaching cannot say infants for a geriatric patient. Walking if your patient is bedbound. Ensure that teachings adhere to the plan of care and that the frequency is maintained as stated on the plan of care. Any visits outside of the stated frequency must be covered by a PRN order. Ensure that the date, time, type, and purpose of the visit is indicated and the amount of time for the visit falls within the minimum allowed allocated time for the type of visit. Progress towards goals have to be addressed on every single visit. Progress must be realistic and measurable, and barriers to progress identified. Example, patient responding well to new antibiotic amoxicillin as evidenced by no fever this visit. Temperature 98.7 degrees Fahrenheit compared to last week's reading of 101.4 degrees Fahrenheit. Document all changes in the patient's condition, stating clearly improvements and declines in condition. Each visit must address an intervention listed on the plan of care. Any additional issues addressed can be documented under addendum. Note any changes on the plan of care, such as new post-hospital orders following a resumption of care. Ordered parameters on the plan of care for vital signs, blood sugars, weights, etc. must be followed. All vital signs outside the stated parameters on the plan of care must be reported to MD while still at the patient's home. This includes all unusual findings. Note down who you spoke to from the doctor's office. If the issue is not resolved at the time you are at the patient's home and are still awaiting a call back from the doctor, contact the agency's case manager and let them know so someone can follow up with the MD's office. Note down who you spoke to at the agency. If the issue is critical and/or could be exacerbated to critical status, do not leave the patient. Call 911 and stay with the patient until help arrives. Document that patient was left in the care of emergency medical services personnel, and if known, the hospital patient is being transported to. Always recheck all abnormal findings prior to leaving the patient's home. Patients on dialysis and those with heart failure often need their weight monitored. Inform the case manager of changes related to these health issues if weight monitoring is not on the plan of care or if unable to weigh the patient. SN may obtain ankle circumference measurements and report any deviations from the baseline to MD if unable to weigh the patient. Ensure that patients stated to be weighed are weighed as often as stated on the plan of care. Ensure that all vital signs, temperature, pulse, respiration, weights, blood sugars, O2 sats ordered, are also documented in the patient's vital signs sheet, usually inside the patient's folder in the home. Check your agency's policies on blood sugar monitoring. Due to increased risk for cross-contamination, use of the nurse's glucometer to check the patient's blood sugar is usually prohibited. Use the patient's own blood sugar monitoring machine. If unavailable, contact MD to obtain orders to assist with helping the patient obtain one. Blood sugar readings should indicate if it is random or fasting. All new, changed, or discontinued medications must be indicated on the nurse's note and updated on the medication profile. All antibiotics must show a start and end date and the reason the patient is taking them. Remember to enter all antibiotics on your infection control records and instruct patient on the new antibiotic. Instruct patient on proper disposal of expired medications, if any. A communication note is needed for all changes in a patient's status or plan of care. Example, falls, new wounds, new orders, new doctors, etc. Notify MD on all changes and new problems identified at the patient's home. Document interventions done or attempted. Indicate all names of the persons spoken to at the MD's office and the home health agency when communicating changes. If the patient reports an ER visit or hospitalization, the first goal is to prevent rehospitalization. Collect as much information on reasons for hospitalization and communicate to the care team, case manager, MD, for revisions, re-evaluation, resumption of care assessment, and changes to the plan of care to be effected immediately. Update all new or changed medications on the medication profile. Patients with diagnoses of Alzheimer's or advanced dementia cannot be taught alone. Each teaching needs to be done in the presence of a caregiver and document who the caregiver was. PT-INR tests are time-sensitive and must be performed as ordered, and results called in to the ordering MD. Write a communication note with any new verbal orders given by MD. Inform patient, caregiver of new changes to medication dosages, and confirm availability of new dosage amount and quantity at home. If notifying MD via fax or phone, always include the current warfarin dosage patient is on. If INR is low, below stated parameters, add teaching on ways to avoid blood clots. If INR is high, then make sure to include teaching to report for signs of bleeding such as blood in stool or urine, etc. Also, instruct on diet choices or changes and vitamin K interference. List medications exactly as written on the bottle. Example, if warfarin is listed on the med bottle, put it down as warfarin, not by brand name Coumadin. For new warfarin patients, obtain the name, phone, and fax number of the ordering doctor for appropriate and prompt coordination of PT-INR results. Ensure that all physician orders are completed and results called in sent to MD for ordered lab tests such as PT-INR, hemoglobin A1C, CBC, CMP, etc., and all communication with the physician regarding test results and new orders received is done and case manager notified. For new antibiotics, find out the reason the antibiotic was prescribed and do an infection control report. Update new med on the medication profile with the start and stop date, dose, frequency, indication, and ordering physician's name and phone number. Ensure the patient has no allergies to ordered antibiotic, and instruct patient caregiver on possible side effects, adverse effects of the medication. When pre-filling pill boxes, document whether or not all meds are being taken as directed from the pill box and the number of days the pill box was pre-filled for. Notify the agency if you need a translator for language barrier issues during visits. Remember, for a visit to be billable, there must be at least 2 components to the visit. You must perform an assessment and a skill. Your assessment is the first component. A skill is the second component. Skills include labs, IV, wound care, diabetic foot inspection, etc. Document all supplies used during visit. Remember to instruct the patient on emergency preparedness for seasonal disasters and diseases such as hurricane season, flu, pneumonia season, and importance of immunizations, vaccinations during the applicable seasons. Documentation do's and don'ts. Adhere to patient confidentiality and privacy regulations. Use clear and concise language when documenting. Document care in real time to ensure accuracy and avoid memory gaps. Adhere to home health agencies' policies and standards. Stay informed about updates or changes in documentation requirements. Include relevant patient information, such as demographics, medical history, medications, allergies, etc. Document patient and family education provided. Use only standard and commonly accepted abbreviations. Document any known allergies or adverse reactions to medications or treatments. Include details about the nature and severity of reactions. Document any changes in the patient's condition, including new or worsening symptoms, and note down the interventions and outcomes. Document any communication with the patient, family members, and other healthcare providers. Include details of discussions, instructions given, and responses received. Check for completeness and accuracy before finalizing entries. Avoid vague or ambiguous language in documentation. Be specific and provide details. Use a single line to strike through errors, write the correction, and sign and date the correction. Avoid making assumptions about the patient's condition or responses. Document what was observed and measured, rather than interpreting or inferring. Avoid delaying documentation, as this can lead to inaccuracies or omissions. Use copy and paste features judiciously. Ensure that information copied from previous entries remains relevant and accurate. Tailor each entry to the specific patient encounter. Do not share login credentials for electronic health record systems. Avoid documenting personal opinions or judgments about the patient or other healthcare providers. Stick to objective and factual information. Avoid leaving fields blank or documenting incomplete information. Document changes promptly and take appropriate actions. Always remember, if it's not documented, it was not done. Thanks for watching. For more videos like this, be sure to subscribe. If this video was helpful, hit the like button. It helps others find it too. For helpful downloadable digital resources on home health management, check out the links below. For questions and insights, drop a comment. And if you know someone who could benefit from this video, feel free to share. See you in the next one.